Good afternoon, everyone. Welcome to this session on antiretrovirals for treatment and prevention human rights issues. My name is Jonathan Cohen, and on behalf of my co-chair of the UNAIDS Reference Group on HIV and Human Rights, which is sponsoring this session, I'd like to welcome you this afternoon. The UNAIDS Reference Group on HIV and Human Rights is mandated to advise the joint UN program on HIV/AIDS on human rights issues. And of course, one of those issues that is increasingly prominent, including at this conference, is the issue of antiretrovirals for not only treatment but also prevention. I think it's fair to say that when it comes to the issue of treatment as prevention, the question we are asking is not if, but how. We now have evidence that among many prevention tools, treatment of people living with HIV has higher efficacy than anything else. Higher efficacy than male circumcision, higher efficacy than treatment of other sexually transmitted infections, higher efficacy than pre-exposure prophylaxis, higher efficacy than microbicides, higher efficacy than any other biomedical prevention intervention that is generating much excitement. With treatment as prevention, we have a kind of perfect storm where the one thing that helps to prolong the lives of people living with HIV and that has the greatest clinical benefit for people with HIV also is incredibly effective at preventing the onward transmission of HIV. And the reason for this is probably more clinically complicated than I could express, but basically it's because treatment renders people non-infectious by reducing the level of virus in people's blood to undetectable levels. Yet we also know that treatment as prevention is complicated to implement and only works in certain conditions. And we are going to hear about some of those conditions today and talk about whether the conditions are such in developing countries, in poor nations, that treatment as prevention can be a realistic strategy for ending the epidemic. Even here in the United States, we know that only about 25 to 30% of people living with HIV have undetectable viral load. In order for treatment to have the preventive effect that we want it to have, that percentage needs to be much, much higher. We are very fortunate to be discussing these issues in the company of three experts on treatment as prevention and the human rights issues. We have Dr. Julio Montaner from the British Columbia Center for Excellence on HIV/AIDS, a past president of the International AIDS Society, a clinician, a pioneer in demonstrating the efficacy of antiretroviral treatment as prevention. Next to him, we have Susan Timberlake, who is the chief of the Human Rights Division at UNAIDS Secretariat, based in Geneva, who is advising the Secretariat and the joint program on the human rights aspects of treatment as prevention, and indeed the human rights aspects of the response to HIV more broadly. And finally, from Namibia, we have Michaela Clayton, the executive director of the AIDS and Rights Alliance for Southern Africa, a lawyer by training, a longtime HIV and human rights advocate, and a co-chair of the UNAIDS Reference Group on HIV and Human Rights, among many other things. So please join me in welcoming our panelists. In terms of the ground rules for this session, this is going to be a sort of open forum, a kind of town hall. It's part of our effort as a reference group to work in more of an interactive way. We feel that in order for us as a group to advise UNAIDS properly on human rights issues, we should seek input from a broader array of people. So your input and your comments today will be factored into the advice that the reference group gives the Secretariat and the Joint Program on Treatment as Prevention. So please do think about your comments having that impact. And I'm going to be integrating audience input throughout the session. And I also want to inform you that this session is being filmed by Nick Feustel. So please keep that in mind. If you're not comfortable making comments that will be filmed and that will appear on the internet, then I suggest you not make a comment. I'm going to begin, how's that for a legal disclaimer? I'm going to begin with Dr. Montana. Julio, thanks so much for being here. We've heard from you on this issue many times, but perhaps you could tell us, from your perspective as a pioneer implementer of treatment as prevention in Vancouver, Canada, how did you do it, and why did treatment as prevention work in Vancouver?
So let me say a couple of sort of introductory remarks so people understand exactly how this came about. The first thing that I want to highlight is that while I live in a rich country and a rich environment with socialized medicine and free services for people infected with HIV, including treatment, including access to laboratory testing, specialized laboratory, etc., there was a point in the mid-2000s when the Deputy Minister of Health phoned me up. She knew me personally. She had worked with us before. She respected our work tremendously. However, she called me up and she said, Julio, we have a problem. The budget for treating people with HIV has been rising 3 years in a row in a steady slope. You need to be careful. Even a good thing can become unaffordable. And I turned back to her and I said, Penny, you're making a mistake. You're talking to the wrong person. You need to fix the prevention campaigns. When you fix that, I'll stop treating people. But for as long as there is increasing numbers of people being infected in BC, I need to treat them for their benefit, but also because treatment stops transmission. Now, little did I know that that was going to lead me into doing a whole lot of work to actually characterize to what extent treatment decreased transmission. And in our own environment, treatment became a game changer because by us being able to demonstrate that treatment, in addition to preventing morbidity and mortality and preventing transmission, allowed the government to differentiate between other health initiatives and gave us really free access to funding. So it was out of the desire to support what I consider the essential and fundamental human right of my patients to access treatment that I used the treatment as prevention paradigm to support this contention. Having said that, in order to expand now treatment, we needed to create an environment that embraces the populations that are most at risk in a favorable way with low threshold services so that we can have maximal impact for their benefit and for the benefit of the community. And in order to do that, we had to fight every battle. I mean, it's not by chance that we have a supervised injection site initiative in Vancouver. It's not by chance that we have one of the most progressive harm reduction programs. It's not by chance that we now have brothels operating in Vancouver with the provincial government being basically tolerant of this activity even though it's illegal. We have worked with the government and with the communities, and when the government did not agree to work with us, we have gone all the way to the Supreme Court of Canada and we have fought them, and eventually, lucky enough, we have won. So the point that I'm making is that treatment as prevention is the best thing that ever happened to universal access. The notion is simple. The implementation is complex, and it requires multiple layers of programs that will work synergistically to facilitate access to testing and care by people often very marginalized in our society. If we don't succeed at doing that, treatment as prevention will not work.
Thank you, Julio. Let me just ask you a follow-up, and I want to pick up on the very first half of your first sentence, which is that you live in a country with universal access to healthcare. So what that means, of course, is that in a treatment as prevention program, the drugs are free, the diagnostics are free, the labs are free, everybody's insured. Can treatment as prevention work in a country that does not have a healthcare system like Canada's?
No.
Okay.
Look, Canada is a country with a socialized medical system, but the only province that has a true, fully free funded healthcare service, including antiretroviral therapies for people with HIV, is British Columbia. And the only province that has a focused HIV program in Canada is British Columbia. Not by chance, British Columbia is the only province that has seen a decline in the number of new infections diagnosed year after year. We now have a greater than 60% decrease in new infections, and we continue to see lower and lower numbers every year. The rest of the jurisdictions in Canada have had either stable or actually increasing rates. The reason is because those programs have what I call a perverse Darwinian feature to them, which means that the treatment is available. However, you have to come and get it. If you can find your way through the system, you'll get it. If you don't, you won't. And what happens is that people operate under the false impression that by doing this, we're saving money. So we're saving money on testing, we're saving money on antiretroviral therapy. By putting copayments, we generate disincentives for people to access the treatment, and therefore, we are actually making the situation worse. BC is the only place where we do this. We bring the service to the people. Not only we bring the service to the people, but when it comes to identifying harder to reach populations, we try to identify what are the barriers that act as competing pressures for you not to access the treatment or the testing, and we try to specifically diminish them so that we can build the treatment onto the services that you want to use so that they will create a synergy. If we don't have that, there is no way in Earth that the program can have maximal impact. You may get some impact, but look, in the United States, there is less than 30% undetectability among people infected with HIV simply because the treatments are not available. In Vancouver, British Columbia as a whole, the rate of undetectability is in excess of 55%. No wonder we have an epidemiological impact and you don't see it in the United States. It's as simple as that.
Okay, so we're going to walk over to a very different part of the world, very much unlike Vancouver, British Columbia. Michaela Clayton, yesterday at the bridging session on treatment as prevention, we heard from the Minister of Health of Swaziland, which is in your region. And apparently he has just received funding from, I think it was the Dutch Lottery, to implement a ambitious treatment as prevention program there. Now, what would be your advice to the Minister of Health in Swaziland in terms of some of the challenges, the implementation challenges that they might face in that environment?
There are a number of barriers, and first off, let's think about how many people know their status in Swaziland and in sub-Saharan Africa. There are many, many people who don't know their status, and there are reasons why people don't know their status. The levels of stigma and discrimination that still exist in Swaziland and in other countries in Southern Africa and in the region are still unacceptably high. People still get fired because they're HIV positive. People still get rejected by their families because they're HIV positive. Women still get beaten up by their spouses if they disclose their status to their partners. So there are many, many reasons why people don't want to go for an HIV test in the first place. So access to the system of prevention and treatment is completely compromised by the fact that we are failing to address stigma and discrimination on the basis of HIV status. We are failing to address human rights violations, not only on the basis of HIV status, but on the basis of sexual orientation, on the basis of gender, on the basis of how and when and if you use drugs. In all of our countries in sub-Saharan Africa and in Swaziland in particular, sex work is criminalized. So is drug use, and so is same-sex relations. So, we had a discussion yesterday, or this morning, or yesterday, about the principle of country ownership and sustainability. Country ownership only works in terms of a national program if everyone is owners of that program. And everyone is everyone, not everyone who is a Swazi but isn't gay or isn't a drug user or isn't a sex worker. And I think until such time as we address those barriers that exist in terms of laws and policies that outlaw certain behavior which make it difficult to access testing and treatment, until we address the situation where there are no laws in place to protect against discrimination, and if they are in place, they're not implemented, and until we address the situation at a societal and family level where you still have unacceptably high levels of stigma and discrimination, I think rolling out treatment as prevention in a country like Swaziland is going to be extremely difficult.
Thank you very much, Michaela. And Susan Timberlake, I'm going to turn to you because you've heard now vivid examples from two very different parts of the world. And you, luckily, have a global mandate at UNAIDS. So tell us, I mean, given all of this, what do you think are some of the general human rights considerations related to treatment as prevention?
Okay, being Julio on one side and Michaela on the other, it's I'm not sure what world I live on, what globe, what planet. Anyway, let me throw out some issues that I think we should be talking about. First of all, it amazes me that there's this treatment as prevention, I don't even think we have yet begun to understand a tenth of the implications of it at all levels, okay? One level is for people living with HIV, and it frankly amazes me how little we talk about this. There was a major existential change for people living with HIV when treatment came online and they no longer were dying. Now there's a second major existential change, which is they are no longer infectious if they're on treatment. And yet, I don't hear in the community of people living with HIV a lot of discussion of what this means at a very fundamental, personal, social level, okay? And how that will affect behavior. Meanwhile, we have a world that is, of course, and rightly so, enamored with the idea of treatment as prevention, and that's wonderful. Treatment itself is the fundamental right to life, the right to health. Now, there's yet another reason to treat, and that's because it has a prevention effect. But what does it mean? What does it mean in reality in terms of both the allocation of resources and also in terms of the ethical balance of the way things are? And let me tell you what I mean by that. If we have, fought throughout the AIDS response for voluntary testing and counseling, we never have really struggled with the notion of whether or not we're going to have voluntary or involuntary treatment. We're still fighting as human rights advocates for more and more treatment, and we want these things. But is this treatment as prevention going to tip the ethical balance away from the voluntary, so that now, because treatment is also prevention, there is a reason for states to begin to impose testing in a mandatory fashion and impose treatment? Now, this may sound like a typical, the human rights community is always criticized for being so uptight on mandatory testing and you might say mandatory treatment. And I think we do have to get messages better than we've had them in the past on these issues. But I'll give you an example. In Belarus, there is a law that has been passed that already has mandatory testing and mandatory treatment for certain populations. And the law is very fuzzy, And it's not very clear whether it might just be extended through to the general population. So that's one issue. We talk about positive health, dignity, and prevention. This concept came out before treatment as prevention, and it was seen as a way for people living with HIV to get a handle on all the forms of support they needed to live healthily, to live with dignity, to be able to stop onward transmission. And they recognized that these forms of support were much more than the biomedical. There were social support, there were legal support, there was treatment literacy, and of course legal literacy. But now with this treatment as prevention, what are the implications for positive health, dignity, and prevention? How does an individual know enough to be able to decide when to get tested if they're concerned, when to go on treatment? How will we empower them with the knowledge they need to make the right sorts of decisions, both for themselves and for the wider society? And then finally, if we have a world where we have limited resources for treatment to save people's lives, when will we ever use those resources for treatment as prevention? You know, we've got a crazy conference and a crazy world where half of the conference is talking about nothing but treatment as prevention. The other half of the conference is saying condomize. Well, it's a lot cheaper to buy a condom for prevention than it is to use ARTs as prevention. So it raises a tremendous ethical issues. One more point. We heard a presentation by my colleague Bernard Swartlander about the changing situation where we are going to have increasingly a world where the income inequality and the poverty is within middle and high income countries more than it is within the developing world, which will reduce. In such a situation where you know that the rich will get treatment, but there will be very limited resources for the poor to get treatment, how will we use those resources in the context of treatment as prevention? There are many, many issues, so I'll just throw those out for now.
No, and thank you very much, Susan, for throwing those out. You've thrown out a lot of really challenging ethical and human rights questions, and I want to start actually with one of them. And I want to put a question to the audience, but while you think about your answer, I want Julio to answer it. And it goes to, I think it was your second point, which is, does the public health benefit of treatment in any way change the ethical calculus around mandatory testing and treatment? And I'm phrasing that question intentionally that way. I'm not saying, does it justify forced testing? I'm saying, does it in any way change the way we balance the obligation to test versus sort of the right not to in any way? Does it for you, Julio?
No, it doesn't. I think that we have been very precise in how we formulated all of this. We have said all along that the preventive value of antiretroviral therapy is a spin-off of doing the right thing for the people that need treatment. We said it in 2006 when we made the recommendation, at a time in which the recommendation for treatment was circumscribed to a certain group of people. At that time, it was 350 CD4s. And we said at that time, if we were to treat everybody below 350, everybody who wants to be treated, you will derive a secondary preventive benefit. As it happens, we did also develop a hypothetical, we call it a hypothetical demographic model, saying if and when treatment evolves to the point that is acceptable and of benefit to everybody infected, and you were able to treat everybody infected, if you were, which we know is not possible, that would lead to a virtual elimination of HIV. But it was a model to illustrate the potential utopical effect that this intervention could have. Today, we continue to feel the same way, except that in North America, independent from the preventive benefit of antiretroviral therapy, the guidelines have evolved to the point that, based on the inflammatory causes of unchecked viral replication, a recommendation has been made that treatment be offered, not mandated, but offered, made available to everybody who is infected regardless. So the therapeutic field has moved way over to that side, and what we're saying is it is no longer acceptable to take the patronizing decision on behalf of a patient that you will not be eligible for treatment. What we're saying is, look, we know enough about the bad things that the virus can do to your liver, to your coronary arteries, to your kidneys, and the like, that we are hereby saying, while we don't have all of the evidence, the ultimate piece of evidence, exactly how much benefit you will derive, we feel that the physiological evidence, the cohort studies, and all of the rest of the evidence that we have available supports for you to be offered a treatment. And if you are below 500, and increasingly so if you have viral load that is elevated or comorbidities or as you know, a whole bunch of other criteria, we would like to encourage you to consider taking treatment. That is the appropriate way in which the guidelines are formulated. The problem is that this gets translated into, oh, treat everybody below 500. I mean, look, this button says treat all. A friend gave it to me and I'm happy to wear it. Does that mean that I'm going around pushing pills down people's throat just because they have HIV? No. What this means is we want to have the opportunity, the offer, the availability of the resources for everybody who is infected with HIV to have the freedom to make the choice to be treated. That's what it's all about. And if we do that in any shape or form, but if we expand the coverage of antiretroviral therapy, the preventive benefits, prevention morbidity, mortality, and secondarily, tuberculosis and HIV transmission will be incredible.
Great. So let's spend some time on this issue. Yes. And please tell us who you are.
Hi, my name is Stéphanie Clevers-Loranger. I work at Coxida in Montreal. And okay, so I've been hearing a lot about treatment as prevention since I got here. And in the sentence treatment as prevention, for me it's clear that the emphasis is on prevention. That's what people hear. And the benefit is for the community to have people on prevention. But that's what we hear. That's what we hear. And then yesterday that came up, and again today you're explaining that really it's an access issue, and what's important is to get people on treatment when they need it for their health, and that the prevention effect for the community is just really a secondary, it's like a bonus.
Yes.
But I've heard a very well-known doctor in Canada saying that he was talking about putting everybody on treatment as soon as possible because it's now obvious that it's better for everybody's health, for the person's health, plus it's better for the community. So I'm not saying this is what you're saying, but there's some confusion, and this is definitely, there is some confusion. And Suzanne was talking about ethical balance, and in Canada also we have issues regarding like consentement éclairé, informed consent to testing. You know, people get criminalized. If you're known to have HIV, you're going to have a hard time getting insurance and having a house. So what I'm wondering is if the question here, because what you're talking about is access. So I know that treatment as prevention might be a better marketing tool, but maybe what we're talking about here is universal access. Why aren't we just talking about access and avoiding this confusion that treatment as prevention might be making?
Look, I actually wrote an editorial in The Lancet that is called a hat trick for treatment as prevention, meaning that it prevents morbidity, mortality, and secondary transmission. I don't know how else to say it. I said it from day one. I explained you how this came about. Treatment as prevention, you're right. It was a tool that we use to elevate the value of the universal access proposition. This is the way I explained it to Michel Siribe when he first was appointed to his job. And for us, it was a game changer. look, Irene Day is here with me. She can tell you that on the summer of, I don't remember when the financial crisis first hit, I was on holidays. We canceled my holidays. I flew to Victoria to see my Minister of Health to say, Minister, you cannot touch the HIV program. He says, Julio, everything is on the table except the HIV program because of treatment as prevention. So, you know, you're right. There is confusion. You're right. It's a tool. The treatment as prevention is the protection that I needed, me and we all needed, to make universal access truly appealing to the funders. If that creates a problem, well, we need to fix the problem.
Let's take one more comment on this issue around informed consent, messaging, risk of confusion. Richard Elliott.
Thanks. Hi, Michaela, Susan, Julio. Good to see you. I appreciate you starting off, Jonathan, with the framing around mandatory testing or treatment. But I think in a way that... Sorry, Richard Elliott from the Canadian HIV/AIDS Legal Network. You told us to do that. But I think in a way that's the easy place to start, and it should be a fairly easy answer, which we've heard, which is no, it doesn't change the calculus. The prevention benefit of treatment doesn't mean we can allow or justify mandatory testing or treatment, which is all good, sort of human rights 101. I think where it gets a little fuzzier and where there is more confusion is on how people experience rollout. And I think you said at the beginning, it's not a question of if, but how. And I think that is the question. And I think it's important as we think about scaling of access to treatment, which I fight for a lot, that we try to make sure that the way we do this is going to be respectful of human rights. It's a human rights objective that we're trying to achieve, which is critical. How we get there also has to be human rights compliant and human rights promoting. And we already saw slippage around the whole issue of provider-initiated testing and counseling, and there remains this persistent confusion between routine testing and routinely offering people a test. And sometimes what people mean, oh, of course we mean routinely offering people, but then they talk about routinely testing, which is not the same thing. This is going to intensify and contribute to that confusion. So I think it's very important that we consistently insist upon consent has to be informed, and what does that look like in practice? It's not good enough to just say, we test everybody that comes to this clinic for HIV. Any questions? No. Okay, boom. Oh, you have questions? Here's a handout. That's not informed consent. I don't think that's an ethical approach to rolling out what is a truly important and extraordinarily valuable initiative. But I think we can and we should do better on rolling out treatment as prevention than just assuming that kind of consent unless people say, no, I don't want to get tested. We need to invest in doing it in the right way because that's why we're going to maximize the benefit of it too, which of course we all want.
So I'm just going to did you have a comment, Michaela? And then I'm going to move on to another human rights issue because I think there are so many others besides the one that I chose to go with first. Michaela.
I mean, Richard, just to comment on your comment about implementation. I mean, I think that's key. That's key. The way that we roll this out, regardless of what we call it, is key. And just to illustrate some of the problems that can arise, we did a study a couple of years ago with Human Rights Watch on the Know Your Status campaign in Lesotho, which was a mass testing campaign. And this was even before treatment as prevention. It was a mass testing campaign with community-based health workers going from village to village doing testing. And one of the scary things about that was that in the course of our research, what we discovered was that many of the health workers who were going out there doing testing had absolutely no idea that it was okay to say no to a test. Absolutely no idea. And we've seen more recently in South Africa with the mass testing campaign that's happened. It may not be official policy, but what is happening is that we've had sort of anecdotal reports of women going into clinics to have their child treated and being refused treatment for the child unless they get tested for HIV. So, I think that's what we have to be careful about, is that there will be, as a precursor to increased access to treatment for prevention purposes, there's got to be increased testing. And the way that you do that testing is completely critical. That's completely apart from the ethical considerations of who gets access to treatment first, but yeah.
Great, so let's move on to another, and this is, I think, my best effort to articulate another one of the issues that Susan floated, which is the issue of allocating limited resources, right? So of course, treatment as prevention, the prevention benefit provides us with a great argument for universal access. But the reality is that we don't, or in certain countries, there may not be the resources to treat everyone. So here's the question. Given what we know about the preventive benefits of treatment, is there an ethical, moral, human rights justification to prioritize for treatment people who would otherwise be most likely to pass the virus to somebody else? People in serodiscordant relationships, people who are sexually active. What does this mean for treatment of children who, well, great if they're undetectable, but they are less likely to have been having sex in the first place? Does that raise an equity, a human rights issue around whether we are going to begin to prioritize based on something other than strict clinical criteria? Any comments on that? Yeah. And don't forget to introduce yourself.
I'm Wendy Porch. I'm with the Canadian Working Group on HIV and Rehabilitation in Toronto. And just as you were asking the question, I'd said to my colleague, Elise Zach, our executive director, what does it mean for people with disabilities if we're starting to prioritize who we're treating based on criteria other than what's already there?
Thank you. Other comments on that? Marcus. Welcome.
Thank you. Hi, Marcus Day, Caribbean Drug and Alcohol Research Institute in the Caribbean. I think the comment that Julio made earlier that about offering treatment to everybody. I mean, we have a resource-constrained environment. Well, we know that's bullshit. We know there's endless money out there. There's endless money. There's billions of dollars to bail out the banks and blah, 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 blah. We know, we've heard the story. You know, what's our priority? Is our priority the health of our people? Is the priority, the 1% of the world? And I think that's what we have to fight for. I think that we need to say this is a priority, that when people... I want to see the day where, one, all this bullshit about stigma and discrimination go away. This is another chronic illness. You come into the doctor, you see the doctor, you have HIV. The doctor says, here's your prescription, and how can I help you be adherent? What else do you need? Do you need food? Do you need housing? Do you need whatever else you need? That's what we have to help you with, and we have to help you because for your health, the same way Julio says it, for your health. And the added benefit is that you can have sexual relationships with other people, and there's not. But that's true though, basically. I mean, and if you don't use a condom all the time, it's not going to be a death sentence for your sex partner. And I think that's what we have to move to. I mean, I think somebody said the other day, HIV affects everybody the same way. And I said, yeah, maybe 30 years ago, everybody was dying whether you're rich or poor, but that's not the case nowadays. And so there's a huge disparity, and basically, we have to take away that disparity. And it's health disparities. It's not HIV disparities. HIV is one health issue among a number of health issues that the poor and sex workers and drug users and criminalized people are suffering from, and we need to move that away. And I think that's the way we have to start looking at this.
Great. Yeah.
Hi, my name is Sasha Moore. I'm a jurist with Group SIDA in Geneva. And concerning limited resources, there's a particular problem for one of the key populations in rich countries, and that's undocumented migrants. Switzerland is a country which has universal health care, at least for those who can afford it. We have co-pays, we have deductibles, and we have fees. It's very expensive, and even 30% of the Swiss population has trouble paying these fees. Undocumented migrants cannot. Estimated upwards of 300,000 illegal migrants living in Switzerland, of which 90% are not covered by universal health insurance. These migrants do have access to HIV drugs when they do touch the system. If we get in touch with them, or the university hospitals do, they will get their treatment. they will get their treatment until an expulsion order then removes them from the country back to their country of origin, where they might not have the treatment. The problem with the rollout is that they will get a treatment as it is ordered in the guidelines today. Whether they will get TASP, which otherwise would be covered by the health insurance in Switzerland, is one question. Whether they would get TASP when they return to their country of origins is another question. Whether they would even get treatment in their country of origin is the last question. So my question is, how are we going to deal with that if even rich countries, Switzerland, there's absolutely no way that we're going to be able in the next 5 years extend universal health insurance to illegal, undocumented migrants. There's just no political will in the country at this point. So how do we do that in that situation? Thank you.
Okay. Do any of our panelists want to, Susan?
I feel like we're a bit in la la land here. And what I mean by that is, you know, there are two things. One is what's going on with people who've actually connected to the system and the famous cascade slides. And the other is the other half of the people that we haven't reached and haven't connected to the system. You know, if I wanted to boil this conference down to one slide and one set of issues, it would be these cascade slides, where you see that, you know, first of all, not very many people, not as many people as who need to be are going for testing. Then you see that those who go for testing, they fall off at different points until at the very end of the cascade, there are very, very few people on effective therapy that reduces their viral load. Very, very few. Now, I see those slides and I just sort of feel ballistic. Why aren't we spending huge amounts of money, or not huge, but some money at least, to research exactly what are the reasons for that fall off? We know there are a complex set of reasons. There's, you know, they don't have enough money to get to the clinic. They don't have enough understanding of adherence. They fear discrimination or stigma. I'm sure there's just a huge, you know, they don't have enough food. All these reasons. But whatever, we should be doing what we need to do to find out what it is that's the cause of all this and then addressing it. But we're not doing that. And that shows that even as we get more and more biomedical responses, we still don't do what it takes to understand the human element of the uptake and adherence to those biomedical responses. So that's one thing. One more thing to say. So that's the people who've connected. Now we've got the second half of those who who are eligible for treatment who haven't connected. I think that we've done the so-called easy part. We've found people who were willing to get tested, willing to take up treatment. The second half are going to be much harder. And these are people who are so stigmatized or so marginalized or so criminalized that they're not going to come forward, and we're going to have to do much better to reach them. And your question, Jonathan, about, you know, is there any ethical imperative to reach those who may be doing more transmission? You know, it's a scary question, but it's also, I mean, I'm getting to the point where, you know, Julio very beautifully talks about what this brings to people's lives. And it means that we need to be, frankly, much more aggressive to reach people, all the people. And if the treatment is prevention, means that we'll reach populations who maybe are more responsible for some of the transmission, that's a good thing as long as they get the treatment and they are supported to stay on it. What we fear, though, of course, is that the law will be twisted so that they won't be supported. They will be criminalized for not having gotten tested or not having gotten on treatment.
Julio. Yeah.
That's a beautiful sort of introduction to my next comment, which really has to do with what we learned over the last 30 years dealing with HIV. I mean, HIV is the big magnifier that all through the history of this epidemic has shed light on all of the problems that we have failed to resolve in society, whether it's drug addiction or sex or whatever. You can go through the list yourself. What we're discussing here, or what the challenge in front of us, is not treatment as prevention. Is the healthcare system of this world that stinks. I mean, that's basically the problem. What treatment as prevention has done is has elevated the value of the proposition to such a level that now we have an urgent need to fix the cascade of care. And we cannot fix the cascade of care if we don't deal with the systemic and persistent and perverse negative attitudes that we have towards the people that are infected with HIV, affected with HIV, or potentially infected. So the challenge in front of us is not to undo treatment as prevention. Is to say, how are we going to make this work? Because this is what our patients need. But at the end of the day, more important than that, is to say, how are we going to fix the healthcare? I remember back in medical school learning that health was a basic human right. There was a holistic definition of the integral need of the individual to be da-da-da-da-da-da. And guess what? We're nowhere near to that. We haven't delivered on that promise. It's all BS. It's in the books, but we haven't done it. And we are sitting in front of the Gardner slide, the cascade of care that looks awful, and people show it, but it's getting better. It went from 18% to 28%. And I feel like puking.
So, Julio, I have a specific question, and then I have a sort of general place I want to take this. Specific question on the cascade in Vancouver, in British Columbia. You mentioned that you have 55% undetectability in British Columbia, which is much more impressive than the 26% in the US. The 45% who aren't undetectable, who are they?
Actually, we have invested tremendous amount of money trying to characterize those people, to figure out who they are, where are they, where do they live, what are the barriers, and so we, the problem is that they are all different. They are all different people, and they all have challenges and reasons why they have not yet either engaged in treatment or decided to go on treatment. And the challenge, I tell my team, it's our job to find out what are the reasons, what are the competing priorities that make it difficult for these people when in need to actually avail themselves from the treatment that is already available to them. And there are, there are pockets, as you can imagine. There are people who are drug addicted, there are mentally ill, there are people who are in poverty, there are people that are in isolation, there are people that have not tested, there are people that are living in reclusion. I mean, the list is very long, and the more you deal with the low-hanging fruit, in other words, as you were pointing out, the easy one, the easy part, it gets harder and harder and harder. But if I show you the cascade of care in British Columbia, we have characterized it on a yearly basis since 1996, and I can show you every year gets better. Why? Because we are investing on finding out what can we do for you to make it work for you.
Great. Thank you. Any comments on this issue of the cascade of care and the human rights issues related? Yeah.
Yeah, I'm not really a comment on the... Christine Stechling from the International HIV/AIDS Alliance. I'm just thinking part of the conversation that we're having is about the way that we as the human rights community react to treatment as prevention. And I said yesterday in a different treatment as prevention session that we very quickly become the party poopers. We come to the table and we say it's all very complex and communities are complex and human rights are complex. But we're saying the same thing, and I think there's a trick that we're all missing about saying all the issues that we're discussing, they are the systems issues, they're the same issues. But we need to explain them as in, yes, we all support treatment as prevention for everybody, which is basically saying universal access. And as you say, if it has a prevention benefit, great. But what we know is that it is politically hijacked now, and it will be politically hijacked, especially in those places where there are resource limitations and where the resources for this come from external partners. So somehow we need to come up with a plan on how we speak the same language and say, and not come as the party poopers to the table, but come as the great. But for you to do that in Swaziland, or not perhaps even bad, great that you're doing it in Swaziland, and the way that this will work is like this, so that we have everybody accessing testing, and that there is marital rape is outlawed, and MSM are not criminalized. All those things that we all feel very passionate about, and ensuring that there is no prioritization so that we don't come to those awful decisions. Is it better not to prioritize children because, and we know that this is going to happen in these resource-limited settings. So I don't know what the trick is for our language, but there's something that we are missing as a human rights community to speak together and in a different language that doesn't immediately come as in, well, this is going to be too difficult.
Thank you. Any other comments on this? Yes, please. Excuse me.
I'm Heidi Winston, and I'm a nurse from Boston. And I'm not going to speak for a long time here, but I think the problem is the profit system, it's capitalism, it's exploitation. And that's what it is, and it's the same around the world. You know, and when they had socialism in China, which, you know, was a while ago and it has changed, they got rid of a number of diseases very quickly because people worked together and they ended exploitation. So that's what I have to say. Thank you.
Okay. Other comments on this? Yes. Is your hand up there? Yep.
Walt Centerfit from the Prevention Justice Alliance, and also work for the Los Angeles County Department of Public Health. A couple of the comments on like the cascade issue and the ethical things. I mean, I think obviously finding the reasons why, what people need in order to help them make the choices to stay in care is one thing. Because, however, it's nested within this larger unjust and inequitable system, we end up having some interesting ethical conundrums. For example, somebody who's HIV positive in LA County now can get jumped ahead to a substance abuse treatment bed resident. They can get housing, they can get food. If they're HIV negative in the same social circumstances, they cannot. And sometimes the care system also subjects them, although it's not supposed to the risk of deportation. Like 35% of the people that are on subsidized HIV medications in LA County are undocumented migrants. People say, okay, well, are we giving HIV special jumps in the queue to get treatment? Yes, we are, but is this justifiable? I mean, I think so, because we fight for that, but then that also exposes the naked contradictions and gives us maybe reason to say everybody should have this and more.
Okay, so we have about a half hour left, although I think, Julio, you may have to... We've talked a lot about structural issues. We've talked about health systems issues. I want to bring us to the personal, and which Susan actually did first. And Susan, this was your first point, which I really want to take us back to. You have to go. But before I do that, I want to thank Julio so much for being here. This was such an important dialogue. I wish it were an audience of thousands. I think they deserve to see this. Fortunately, it's being recorded, so everybody please thank Julio, who has another engagement. Thank you. And let me come back as we wrap up to the point that Susan made. And maybe, Susan, I'll give you a chance to elaborate a bit on this point if you wish, which is, what are the personal, the emotional, the existential implications for people living with HIV of knowing that treatment has the potential not only to save their life, but to render them non-infectious to other people. And linking that as well to a comment that Julio made, which is that we will never plug the leaky cascade until we deal with the stigma, the hatred, the antipathy towards people with HIV. And all of this leads me to a question, which is, why does this stigma persist when we know that if treated, a person with HIV is nothing to be scared of? Is it because people don't know this? Is it because they know it, but not enough people are on treatment? And is there some potential to use the idea of treatment as prevention to break stigma, self-stigma and stigma from others, and thereby perhaps lift one of the barriers to people coming forward to getting tested in the first place? What do people think of that idea? Do you want to, Susan?
I'll start us off. I don't really feel like I should comment on the personal aspects because I'm not living with HIV. But I think if I was living with HIV and I realized that I was no longer infectious, I would dance down the streets. I mean, it would be just like a huge, huge weight off of me. And I think there's so many issues of self-stigma that are so powerful and have to do with being infectious, from what I've learned from people living with HIV, that I just think this is so exciting, and a huge shift. But on the stigma, why does it persist? I would like to say that I think there have been two myths that continue to exist. One is that if you get enough people tested so that enough people know that they're living with HIV, stigma will drop. The second is if you get enough people on treatment so that enough people are out there living successfully with HIV, stigma will drop. I don't think we have evidence that this happens. Some people claim it does, and I think that thinking is behind the hard push for the biomedical approach. We don't need to do stigma reduction programs. We don't need to invest in positive health, dignity, and prevention, or do any of these things, doing the legal programs that will help people in the legal arena, because it's not necessary, because if we just get the test and the pills out there, it will drop anyway. But that takes me to your question, Jonathan, that the research shows that there are 3 actionable causes of stigma. One is amazing. It's that people don't realize that stigma hurts. So that, if they're out there stigmatizing, they don't realize that it's really a nasty thing to do. And so one thing you can do is actually talk to them about it and show the kind of harm it causes, and then they start going, oh, that's maybe not a nice thing to do. The second reason that stigma exists is that people still have fears about transmission. So I think that will help. This treatment as prevention, if we get the message out, it will really, really help on that part of stigma. The third is the moral associations. You've got HIV because you are a bad person because you're doing immoral acts. Now that is so much harder to deal with. So I don't know if the treatment as prevention will take that away. But anyway, it's a start. It's a big start, at least on that middle one, that you don't have to be afraid of someone living with HIV.
Any comments on that? Yep, in the back? Sure.
Hi, I'm Karen Pomerantz. I live here in Washington and work with the Public Health Association. But I'm also a member of a revolutionary communist organization, Progressive Labor Party, and I'd like to invite people to really consider more of the structural interventions as well. And I think if we can't create a world that's based on an egalitarian system, then we can't really eradicate HIV. So I have copies of a pamphlet that I'd love to have your input on about how organizing for a communist revolution can actually create the conditions that reduce the vulnerabilities to HIV and AIDS and many other health issues. So I know this sounds old hat, and maybe people are just discouraged by experiences in the past, But I think we have to think beyond them and think about how we can create a new world that doesn't create the same mistakes that old communist regimes did, and really ensure the conditions of equality so that we can move forward. And I think if we don't do that, we're going to have one more NGO after another, one more program after another that really just doesn't eradicate the epidemic. So thank you for your consideration, and we're happy to talk. Thank you.
Okay, no, that's fine. A little off topic, but so that really I want to come back to this point and just see if anyone has comments on this, because Susan alluded to the potential for treatment as prevention to make inroads into one of the three main causes of HIV stigma, which is fear of infection. But that requires, in a way, getting the message out, which is, in a way, a programmatic challenge, but I'm not even sure it's about getting a message out. I don't know what it is. But do people have thoughts on that? Michaela?
Sorry, I just want to throw something else out there. Julio was talking before he left about how people were asking about the terminology of treatment, treatment as prevention. And he was saying that one of the reasons it was termed at that was in order to sell it to funders, basically, to sell it to donors. So I'm sitting here thinking, certainly in the area where I come from, it's incredibly difficult. There is no political will, for example, on the part of governments to change laws that criminalize, for example, same-sex sex. In Namibia, where I come from, people will still tell you that there are no men who have sex with men in Namibia because it's not African. It's a European colonial imported idea, and it's just not African. But I'm throwing this out, just in terms of the way that we package things. Maybe it would be easier to persuade governments to change laws that act as barriers to accessing testing and treatment if we sell it as treatment as prevention.
Or law reform as prevention.
Law reform as prevention.
Any thoughts on that? How do people think we should talk about treatment as prevention, truly? Because we've heard that it's a way of selling it to donors, and the preventive impact of universal access makes it more saleable. But we've also heard that selling it as prevention can cause confusion, it can cause risk, it can take the focus off the clinical benefit and more on the public health. This might cause slippage in terms of human rights. Do people have thoughts on ways that we can talk about it that will avert some of these challenges? Richard?
Well, I guess one simple thing would be to never just talk about treatment as prevention without also saying treatment for the sake of treatment. As long as we have millions of people dying because they don't get treatment that they clinically need, we can't have the attention shift, the channel be changed to talk about treatment as prevention as the dominant narrative. I recall in all of the debates, 10 years ago, as people were debating the UN General Assembly statements and so on, there was this big tension still between prevention and treatment, and we were hearing a lot of language about how prevention has to be the mainstay of the response, and oh yes, treatment if and when we can afford it for those people. And that was wrong then, and I think it's wrong now. So we should always be saying treatment for treatment and treatment for prevention. I mean, one thing is just to never separate them, because partly it falls back, it's not falling back into the same false dichotomy that existed before, because in a way now we're saying treatment is prevention, so that's a step forward from where it used to be where treatment and prevention were always pitted against each other. But it does perhaps unduly emphasize treatment for a reason, that is a good reason, but it's problematic if it's the only reason when we're still fighting to get treatment for people who are dying.
I suppose the other part of your comment is that we're also fighting for forms of prevention other than treatment. Now, the title of this session is not treatment as prevention. It is ARVs for treatment and prevention, which may not be catchy, but it was deliberate.
And perhaps the way to talk about it, and again, it sounds a bit lame, but it is really about combination prevention. And unfortunately, it's not sexy enough, and we have said it for too long, so people don't use that language, but that's really what it is. It's combination prevention, which includes treatment, and it includes access to legal services, and it includes law reform, and it includes training police officers. It includes all those things, but it also includes behavioral change programs, it includes harm reduction. But because it's complex and it's kind of a mouthful, and because there's so much negativity around some parts of treatment, combination prevention, people don't use it. But really, truth be told, this is what it is, and we could use the language. We could really be better in using combination prevention language.
Great. Susan.
This is just a weird off-the-wall idea that I haven't
why
thought
we're here.
through. You know, I'm just thinking of the fact that the AIDS movement, well, the AIDS response has been at the hands of the AIDS movement. I mean, whenever there's been any sort of success, it's been because people have mobilized around their rights and demanded them. And now I'm thinking that, you know, one of our problems is that we're worried that we don't have the kind of activism and advocacy that we've had in the past. And this, again, to me, I don't know if we've thought through these implications for treatment is prevention, if we say that, and prevention is treatment. I don't know if it works that way. But what I'm thinking is that people have demanded the right to treatment, and they've at least got that right recognized, and half of those who need it have it, and the other half are still demanding, and we're helping to demand with them. But this treatment as prevention means that those who are not living with HIV should be out there demanding treatment. And it might be a way to bring together, to widen the movement out into the wider society and break down some of this dichotomy between the infected and the uninfected that still poisons a lot of the discourse in a way. So I'm just thinking that have we really thought through how we can build a movement around this, bringing in people who are, you know, demanding treatment for all the right reasons.
So in a way, positive folks and negative folks are united against the virus. And ARVs are our number one tool to make it go away. Yeah.
In terms of, sorry, it's Alison Symington from the Canadian HIV/AIDS Legal Network. In terms of thinking about treatment and human rights issues, most of these conversations seem to focus more on sexual transmission. But of course, treatment is also given to women to prevent transmission to fetuses and infants. And I was just wondering on your insights in terms of how the treatment as prevention push is actually impacting on gender inequality and women's rights violations. I mean, I can see a huge advance if women are able to access treatment and exercise their reproductive rights. But then is there a flip side if women can get treatment to prevent transmission to an infant but couldn't get treatment for their own health? Does that make women even more seen as just, you know, baby carriers as opposed to people in their own right? Is there a flip side to how it impacts on gender inequality?
Now, while you're thinking about that, I mean, my understanding clinically, and I am far from an expert on this, is that probably the best way to prevent vertical transmission is to treat the mother. So even if you're using a pure public health frame, it's not just PMTCT interventions during pregnancy and labor, but actually full antiretroviral treatment. The mother is undetectable. That's how you prevent onward transmission. But I think your question is really valid, because is that how it's playing out in sub-Saharan Africa? Is PMTCT being done in a comprehensive way whereby positive women are being provided with treatment for their own clinical benefit, and then through that contributing to preventing vertical transmission?
I mean, I was thinking about this the other day. Sorry, I was thinking about this the other day. I mean, one of the benefits of treatment many women, as you know, in sub-Saharan Africa are, because of inequality in relationships, are not able to insist on safer sex or to, okay, let's keep it there for the while, to insist on safer sex. And it's generally the man in the relationship who determines when and how sex takes place and if protection is used or not. And I mean, I think one of the upsides, if treatment as prevention was a reality and was really accessible in sub-Saharan Africa, it would be an incredible tool for women in terms of taking control of their own, their ability to protect themselves. I mean, it's a lot more, treatment as prevention is a hell of a lot more discreet than a female condom, which is as discreet as a shopping packet. I mean, but I'm just trying to think about the reverse scenario in terms of PMTCT, how this would play out in terms of PMTCT. I mean, I think probably, I mean, it depends where you are in sub-Saharan Africa in terms of whether you get PMTCT plus or not, whether you treat it as a vessel for a child or whether it's a more comprehensive service. But I mean, I'm thinking if treatment as prevention does become a reality in sub-Saharan Africa, it would certainly alleviate that situation of women being seen as, having prevention just for the sake of having a healthy child, as opposed to being a person in their own right who deserves prevention as well.
Be interesting if Julio were still here to ask him how it's playing out in Vancouver, because I would guess they've virtually eliminated mother-to-child transmission of HIV in BC, and yet we know that only 55% of people with HIV are undetectable. Many of those are women of reproductive age, so something's missing there. Women don't have universal access to treatment, even though perinatal transmission is eliminated. Susan?
Well, just to say something that sounds quite negative, I mean, I think there are many great reasons to have a plan to eliminate mother-to-child transmission, but it's also an example of giving someone treatment to prevent transmission to another, not to help that person necessarily. So it's an example of what we could have with treatment as prevention. And when it's rolled out in nasty ways, I mean, the nastiest way to prevent mother-to-child transmission, of course, is to sterilize the mother or have a forced abortion. That's the worst. The second is to have some sort of mandatory testing and some sort of mandatory treatment. Now, we're seeing the mandatory testing. We're not seeing as much of the mandatory treatment, but I think it's because the resources aren't there. But if our advocacy to create this movement to eliminate mother-to-child transmission results in the resources, then we may see mandatory treatment of the mothers. And the point is that, if people don't understand treatment anyway because of the complexity of it and all the side effects and the cost and everything that's involved, and we have failed to educate them so that they are treatment literate, how in the world or do we think that we can do a good job in also conveying all the complicated issues around prevention, treatment as prevention? It's daunting. I mean, I don't want to sound that negative, but I think we just have to keep a very close eye on the ball here and try to figure out ways that the resources that are allocated either for mother-to-child transmission or for treatment as prevention put a tremendous amount of resource into empowering the community involved so that they are empowered to take up the thing for their own reasons versus it being imposed on them for social reasons.
Very deftly put. Any other comments on this issue of women's human rights and treatment as prevention? Are women particularly vulnerable to human rights infringements in the context of treatment as prevention because you've got the interests of children involved? If health facilities are willing to sterilize women, then maybe they're willing to force them onto ART, or certainly force them to get tested. Forcing people to take a lifetime of ART is, of course, logistically not very easy. Any other comments on this topic? Okay, well, I think, are just about at the end of our session. I really want to thank everyone. There's time for a couple concluding comments, though, on a topic of your choice. So, please.
I just wanted to say I was at a meeting the other day with WHO, including the Director General of WHO, Dr. Margaret Chan, and the discussion was on where should we go with using antiretrovirals for prevention. And WHO is in the process of developing some guidance that will be coming out in the next year or so, as I understand it, that will look at policy and operational and programmatic components for how to use ARVs for HIV prevention purposes. And I made the point there, but I want to make it again here, that I think it's really important as WHO does that a concern about the human rights dimensions of ARVs for prevention in various different ways be fully fleshed out in the guidance that WHO gives at a high level, but also in very practical tools that will affect how countries implement ARVs for prevention, so that when it comes to how you go about rolling out access to testing and treatment for this additional prevention benefit, you aren't going to start cutting corners when it comes to making sure people give informed consent to getting tested, that people aren't pressured into going on treatment for others' benefit, but rather are being given information to make a decision about treatment for their own clinical benefit. I think that's going to be important. So for civil society, we should be pushing that with WHO in the months ahead as they develop that guidance, because that's going to be a key point. That stuff does get down to country level, and it has an impact, I think.
I also want to make one concluding comment, and then I'm going to let Susan and Michaela, if they wish, and it sort of relates to Susan's La La Land comment, which is, I feel like so much of what we're saying assumes a scenario where a person who's been recently diagnosed with HIV sits down with their medical provider in an armchair and has a discussion about the pros and cons, and is it time, and what's my CD4 count, and what are the pros and cons, and the doctor says, well, you know, one consideration may be that if you have a partner or you're sexually active and you get treated, you may not infect them, but on the other hand, it's your choice, and this is the clinical benefit of starting at this point and that point, and this is what the data shows. And this is just absolutely not the reality for the overwhelming majority of people living with HIV, and I don't care what country you're talking about. I mean, this is true in the United States. It's certainly true in much of Southern Africa. So I say that only as a way of sort of wrapping up and suggesting that the human rights approach to treatment, or ARVs for treatment and prevention, is very much about that reality check, about getting us out of the La La Land, out of the utopia, onto the ground. It is because human rights advocates desperately want this to work that we raise these issues, not because we want to rain on any parades. And I think that we saw today a really good dialogue between someone who is a fierce proponent of these interventions and people who are concerned about many of the human rights implications. So thank you all so much for participating. I think this is exactly what the Human Rights Networking Zone is for. Thank you, Susan Timberlake, Michaela Clayton, for shepherding us through some of the really tricky issues here. And this will be posted online, and we encourage you to continue to be part of the conversation. Thanks.